Well, hello everyone. Welcome. Welcome on this Sunday at midday afternoon for the majority of us. My name is Anna Sanjuan, and I'm really delighted to welcome you. Today, we are having what we call a free introduction to a summit that we are hosting next weekend. And the conversation that we'll be having is on solving chronic pain, a new pathway to relief. This is the Open Center of New York, and I welcome you very much to our home. The Open Center is this country's longest running educational institute dedicated to holistic health. And since 1984, the Open Center has been a home base where people are invited to come to study healing arts, spirituality, personal growth. They come to meet each other, to study, to practice, and this has been happening for 36 years. Since COVID, the Open Center very quickly brought all of its programming online. And while we are sad not to be with each other face to face, and we do look forward to coming back together face to face, what has happened is we now have an international audience of people across time zones who are accessing very wonderful, very important information. So on behalf of the Open Center and all of its staff, we're very happy to welcome you. So next weekend, January 22nd, 23rd, and 24th, we are hosting a live summit. We are bringing together approximately 20 of the leading scientists, doctors, researchers, and experts in the subject of chronic pain. This is a very important topic. It's a topic that affects everybody at some point in your life, where there is chronic pain that is being experienced. And when you go to your medical professional, they say that it may not be treatable, it may not be solvable. And this gathering of clinicians and experts say that that simply isn't true. They are understanding chronic pain 20 years ahead, very progressive new theories about chronic pain that say that, in fact, it is very solvable, that we have a lot of our own innate resources within us to address it, and that a lot of it has to do with the question of feeling safe, the question of threat versus safety. So this is very groundbreaking information. It's about, in the last 10 years, this conversation has really come up. And what we're having today in this really special next hour, hour and a half, is gathering 4 of the co-organizers of the event, the leading speakers of the event, who will be giving us a taste of what they're going to drop into more deeply next weekend, but also setting the stage. And so this is how we're going to do it today. We have 4 wonderful speakers. They're going to talk for about less than 15 minutes each. And then after we go through the conversations, we're going to drop into a Q&A. If you do have a question and you're familiar enough with Zoom to know that there's a wonderful chat button on your bottom bar on Zoom, and you can drop your question in there, and then I'll be picking up and taking questions, almost an hour into our time together. I think that should be about it. So without further ado, I would love to welcome Dr. David Hanscom. He's coming to us from the West Coast of the United States, and he is one of the leading organizers of this event. Say one word. He is an orthopedic spine surgeon who is specialized in working with people with failed back surgeries. And he stopped offering to do surgeries and said, I've got a better way for you. And he's had an incredibly high success rate treating people with incurable pain, lower back pain or pain in the back, and resolving their issues very quickly and at very high success rates. So with that said, I'd like to welcome Dr. David Hanscom. Welcome, and kick it off for us. And thank you so much.
Very much. I'm excited about this event. This all represents a very, very unexpected series of events. And I did spine surgery for 32 years. I spent 8 years being that very aggressive spine surgeon. And then I developed chronic pain myself for about 15 years with 17 different symptoms. I had migraine headaches, irritable bowel, spastic bladder, back pain, neck pain, burning sensation, skin rashes. It didn't stop, but nobody could tell me what was going on. So I went on this 30-year quest that sort of ended this year when I met Dr. Stephen Porges, Les Aria, Dr. David Clawson, who's not on the phone yet. But the bottom line is every symptom is completely explainable. And what happened about 2 years ago, I met Dr. Les Aria, who's a pain psychologist at Kaiser, and he had been starting to use my concepts called in this book called Back in Control. And it turns out that every clinician that solves chronic pain has a very nice relationship with their patients. The patients feel safe. And then Les had been doing this for a while on his own style. Then I've learned a lot from him. Then we both ran across Dr. Stephen Porges, who wrote what's called the polyvagal theory. He'll explain that in a second. But it gave us a framework to explain our clinical success. So Dr. Aria and I have seen hundreds and hundreds of patients go to pain-free. It's actually disturbingly simple. My patients think, you better go, what? I lost so many years of my life because of this. It's not very hard. The other elephant in the room, there are over 100 million people in the US with chronic pain. Okay, and it keeps growing. That means we don't know how to treat it as a medical profession. And the answers are actually right there in the literature. So Dr. Porges was allowed us to give us the framework to explain the body's reaction to the circumstances in terms of the body chemistry and immune system. And we have learned the language of safety versus threat that Dr. Porges will talk about. But what this summit is intended to do, and I'm sorry, Dr. Clawson is not on the table yet, but he's been a remarkable insight into the body's actual function as far as metabolism, which is the rate at the body functions. Also, the communication cells called cytokines. So he's given us a tremendous insight from a basic science level. What this summit is doing, it reflects the collective consciousness of this group. And we, amongst ourselves, have already been successful. Most of mainstream medicine does not consider chronic pain solvable. We see it solvable on a regular basis. It also turns out that these principles apply to all chronic diseases, both mental and physical. And we'll explain that as this goes along. So this summit is intended to be a punctuation point and sort of a jumping off point for further research. But there are very, very few people in the country that are reflecting this combined set of disciplines that we're reflecting. So I'm extremely excited to be a part of it. And by the way, Dr. Aria sort of put me up to this a little bit too, so I have to give him credit or blame, depends how you look at it. But no, it's been really exciting working with this group. Everybody keeps asking questions and questions and questions, and we keep coming up with answers for each other, which brings more questions. So I'm very excited about the whole energy behind this summit.
Fantastic, David. David, could you talk to us a little bit about who this summit and the questions, the conversations around chronic pain, who this applies to? Like who in our medical professions and other professions is this a situation for?
Well, some of the summit is technical, a little bit above people's heads, but most of it is well within the reach of the average patient to understand the concepts. They're not that hard, really. And it's also intended for any person in the healthcare system, whether it's an occupational therapist, physical therapist, psychologist, massage therapist, acupuncture, all that applies. And then, of course, with physicians also. But again, what Dr. Porges has taught us, as you create a sense of safety, it has profound effects on your body's chemistry and immune system. And so when the things that we have historically thought have been, quote, psychological, have really been the body's total response to the environment. So it's helpful for the patients to understand what's going on. It'll be helpful for any provider to help do their job better. And then amongst physicians, I actually quit my surgical practice to flip medicine on its ear. Because right now we're treating just symptoms, not the root cause. We're hurting people, not helping people. I was seeing 3 to 5 patients every week having surgeries done on normal spines with devastating results. And I was watching hundreds of patients go to pain-free with essentially no risk, minimal cost. And the contrast became so significant that I just quit about 2 years ago. So I do that. This is my full-time energy to get this out into the world.
And why is this, like we've talked before, and you said that the conversation that will be had today and next weekend is 20 years in advance of the current conversation on chronic pain. You know, when people are gathering in conferences around the world, they're 20 years behind this conversation. Can you tell us a little bit why that is?
I've been in medicine for 42 years, and I don't want to spend too much energy throwing medicine under the bus because it's just the way all of us were trained. So I historically is one of those people that treat as symptoms, but the essence of the problem is that you have a person. This person has a certain set of coping skills. Maybe they're high, maybe they're low. They vary day to day, week to week. They also are based on your childhood coping mechanisms. And then you have your circumstances. Whenever your circumstances overwhelm your coping mechanism, what's your body going to do? It's going to respond in a way to keep you safe. Turns out that a mental threat and physical threat are treated the same way. Every living creature responds to safety versus threat. So you get this neurochemical response that keeps you alive. So what happens, you have the interaction between your circumstances and your brain, and that's where the symptoms arise. But in medicine, we're treating just the symptoms out here. We're not treating the root cause. It's like trying to put out a oil well fire with a garden hose. The fuel keeps coming up. And guess what? We have 100 million people, like I said before, in chronic pain. We are not addressing the root cause. So in modern day medicine, we have no time to talk to the patient. So we don't know you. We don't know your circumstances. It doesn't take very much time, by the way. I am not a psychologist, as Dr. Aria and Dr. Porges will confirm. But I do listen to my patients enough to know that life is tough. Most of the time when patients came into my office, they were undergoing some pretty major life change, and there were horrible circumstances. So what happens, you're going along in life doing reasonably well. You have an overwhelming set of circumstances. Your body's chemistry changes. And again, a lot of it, as Dr. Porges has pointed out, is modulated through the autonomic nervous system, which includes your immune system, which attacks your own body and creates disease. So by calming down you can't avoid stress. Remember, the stress that's the most stressful is the stress that you can't solve, right? The ongoing stress that you can't solve is a problem. So there are ways of processing that stress that has less impact. Then the other part of the equation, which Dr. Porges and Dr. Aria will talk about, is you can increase the resiliency of the nervous system. So between increasing the resiliency of the nervous system and creating better ways to process stress, guess what? The symptoms start to drop down. But if you're treating just the symptoms without looking at that interaction, it's a problem. And in modern medicine, doctors are actually forbidden to talk to their patients. And my goal of this whole group is to understand to the insurance companies into the world, by not allowing us to talk to our patients, allowing them to feel safe, creates real physical damage to the body and creates disease. And that's what's happening.
So this perspective would invite a pretty significant overhaul in how medicine is delivered.
Absolutely.
And how the relationship between the patient and the doctor as well, which is a healing relationship or could be.
Right.
And so this is a new way of looking at all of these dynamics. And you all are so wonderful that you're the pioneers, really banging on the doors saying, hey, we have to talk about this and we have to see this, because like you said, hundreds of millions of people are struggling with some type of diagnosis like this, and increasing all over the world. Yeah.
Well, the historic pain summit, which again is traditional medicine of doing physical therapy, injections, medications, behavioral modification. So you're treating the symptoms again.
Mm-hmm.
And this whole root cause, by the way, is not new news. This has all been in the literature for over 50 years. And somehow mainstream medicine is overlooking the data that's already there. So this is not, we're not inventing something new. We're just harvesting what's already been there. And it's been effective actually for hundreds of years.
That's great. So I know that one of your partners in crime is Dr. Steve Porges, and he's with us today in this conversation. So this sounds like a good opportunity to invite him into the conversation. And Dr. Porges is a pretty spectacular background and resume. So I can just encourage people to go do a little bit of research on him. He's considered the founder of what we call the polyvagal theory, which is a fairly new, it's an interdisciplinary way of understanding the body and the nervous system. Dr. Porges has published more than 350 peer-reviewed scientific papers on across several disciplines, and he's been cited more than 38,000 times. So this man is busy, and he is well regarded and well referenced. And so I'd love to welcome you, Dr. Porges, into the conversation. You corrected me and said, no, you must call me Steve, because that created more safety and more of a rapport, which is you living into the importance of that. So I'd love to welcome you and share with us what your how you see yourself involved in the summit, and talk to us about chronic pain.
Well, thank you, Anna. The magic word is accessibility, and I think David discovered that, and of course Les is actualizes it in just his presence. The point is that as mammals, we actually request others to be accessible to us, to be safe. And if we look at the neurophysiology, the neuroanatomy, the neurobiology of the evolution of vertebrates, we realize that mammals have something quite unique. Not only do they detect threat like other vertebrae, they detect safety. So if you have a dog or you have any type of mammalian pet, they're always looking for cues of safety. And you know when your dog is safe, your dog will go on the back, and you know those cues. But something happens along the way. We know that our children are that way when they're very young, but something occurs when we get older. We think that we should live in a world that's under a constant evaluation. So we shift the word from threat to evaluation. And we all live a 24-hour, 7-day-a-week evaluation model. And for me, academics was that prison of chronic evaluation. But evaluation is a trigger to our physiology to say that our bodies are under states of threat. And in an environment that's under chronic evaluation, is under chronic stress, and our body's homeostatic function, the way we regulate our organs, they're all disrupted because our nervous system is now prioritized to deal with threat. Now, when I met David and Les, I was really, I would say, tangentially associate with pain, other than the pain that I suffer in my day-to-day life. But I realized, they came to me and said, you know, the treatment of pain to make people pain-free is very much linked to your ideas about polyvagal theory. And I had not really conceptualized that until that interaction. What they were really saying to me was the physiological state that their clients are in determines whether or not they're in pain. And of course that was true, because if your body is in a state of defense, mobilized with a high sympathetic arousal, well, pain is part of that defense system. So your body is going to now ramp up the pain. But what they had discovered on their own, not with any mentoring, what they had discovered was that if you interact with your patients, interact with your clients, you're conveying with them cues of trust, cues of safety, you're calming down their physiology. And as you calm the physiology, you're triggering a neuroception. This is where the nervous system detects safety, as opposed to a neuroception of risk, or nociception, a detection of pain. Your clients are detecting that they're safe in your presence. And now that defensive physiology is displaced by a calm, supportive, socially interactive physiology. So in many ways, the route to pain-free is a route to becoming social, meaning accessible. See, we misuse a lot of words in our society. We think social is active, or running around all the time, going to bars and drinking and moving around. Sociality is being safe enough in the presence of another that your body's no longer in a state of threat. So sociality is how we mitigate threat. And what Les and David discovered was sociality with the therapist and with the physician was sufficient to downregulate the physiological states of their clients so that the threat dissipated, and with the threat, so did the pain dissipate. So we start seeing this beautiful interaction. And when David gave the preamble about his own history with all these medically unexplained symptoms, medically unexplained symptoms are the byproduct of an autonomic nervous system that is under chronic threat. You get that autonomic nervous system out of a state of chronic threat. The medically unexplained symptoms, they take care of themselves because the nervous system, our autonomic nervous system, instead of defending and protecting us from the constant threat, our nervous system is there to support our bodily processes, our homeostatic processes, to support health, growth, and restoration. So I will tell you that it's been a remarkable journey for me, meeting these very interesting explorers on the way of utilizing what for many of us, or for let's say some of us, has been a very intuitive and obvious pathway, to see them translated into a medical problem that affects millions, hundreds of millions of people. Because I had not thought about that. My work had been more in the world of trauma, in the world of autism, in the world of more mental health disorders. And I hadn't thought that much about chronic pain. So I really appreciate them bringing me into this wonderful family that is being helpful to many, many hundreds of thousands of people. Thank you.
That's fantastic. May I ask, Steve, the polyvagal theory has to do with the vagal nerve.
Yeah.
Could we even drop into a little bit of the anatomy and
Well,
what that really means?
we need to drop into the notion of what happened on this evolutionary journey to sociality. How did mammals repurpose an autonomic nervous system that they inherited from reptiles? Well, they repurposed it by evolving another branch of the vagus that had the capacity to downregulate sympathetic defensive responses and to foster systems of sociality. So that pathway of the vagus, which is a cranial nerve, the largest cranial nerve in the body, going to many of our organs, this newer mammalian branch actually originates in part of the brainstem that is regulating the muscles, the nerves that control the muscles of our face and head. That's our social system, our smiles, our intonation of our voice. In fact, the intonation of our voice is regulated by a vagal pathway. So our bodily state, our visceral state, is being projected by our voice. Now, everyone out there knows that, but no one's told them that it's true. They react to that. They realize that's happening. They respect it because when a person's voice goes to a high-pitched squeal, they step back because the person's angry. And if the voice, or anxious rather, and if the voice goes lower and loud and booming, they step back because the person's angry. So their bodies know what's going on. They just don't have a vocabulary for it. Polyvagal theory gave a vocabulary. And this newer mammalian branch became a branch on the journey to sociality. And what sociality became was not merely a social behavior, it became a social neurobiological portal. So it meant that the way of regulating our physiological state was not through drugs, it wasn't through surgery, it was through sociality. And that's what both David and Les do.
Mm. And I'm sorry if you mentioned inflammation seems to be a very big part of the larger conversation with polyvagal theory. Could you?
Well, it becomes really interesting because the vagus is anti-inflammatory. There are pathways from the vagus that are anti-inflammatory. So if we rethink about what is a defensive state, it's an inflammatory state, it's a sympathetic, it's a fight-flight state. If our body is under a state of threat, what are the tools that the body has to react to it? Inflammation is one of those tools. Tell the body that it's being evaluated every day, that you're fearful about being bullied going into work or school, or you're being evaluated and you won't get the raise or the job. You're going to start having inflammation problems as well as other autonomic problems. The model is not to think of any specific subsystem as causal, but think of the nervous system as this very sophisticated yet simple system that can distinguish between threat and safety. Under threat, it's going to shut down its homeostatic resilient functions. Under safety, it's going to be there to help you to build, to regenerate, to enable you to grow and be better. What we don't acknowledge is that this compromise of reacting to threat interferes not only with our physical health, it interferes with our cognitive functioning and our emotional regulation. So if we want to be who we could be, we should be safe. And when in our discussion on it, I talked about this continuum of vulnerability to accessibility. And when we think of vulnerability, we're under threat. When we think of accessibility, our arms pull back and we're connecting with another. So the issue is really to respect our evolutionary heritage. And mammals survived because they could connect with one another. They could communicate, they could cooperate. And even though much of her life is about self-reliance and self-determination, our mammalian heritage, our biological imperative, what our species needs to survive, is to be able to connect with one another.
That's wonderful. Well, that is a perfect segue to invite Dr. Les Aria into the conversation. And then I'm sure we'll be able to all talk together. I'm assuming that Dr. Clawson did not make it just yet, because he may be also somebody to.
I've texted him a couple times. You probably get the time zones mixed up, I'm guessing.
Right. Yeah, that's okay. That's great. We'll have a lot of access to him next weekend. But I'd love to introduce Les Aria, Dr. Les Aria, who's also coming to us from the West Coast. And as I'm hearing from Dr. Steve Porges, Les and David reached out to Dr. Porges and said, hey, your theory really has some very big relationship to what we're seeing in our own practices. And we'd love to connect the dots here. So just a quick introduction to Dr. Aria. You are a rehabilitation and pain psychologist, and you specialize in working with people with complex chronic pain when others have already said there's absolutely nothing that can be done. And you say, no, that's not true. You've developed a unique style that helps patients who are suffering. You help them retrain the mind and rewire their brain and their body. So please come into the conversation and let us, what would you say about chronic pain?
Yes, a good hello, good afternoon, good morning, good evening to some of the folks here. I'm wondering, before I start, could we kind of get all our nervous system in one spot? So I'd like us to do something here, if you don't mind. So just follow my lead, and then I'll do my introductions, and then we'll get going. So I always like to start a group in this manner. So go and take a nice full breath in, pause at the top, and as you breathe out, let the just drop into that. You guys can do better. Let's do it one more time. In, Hello, folks. So I'm Les Aria, and I'm a pain psychologist. I've been a pain psychologist for about 16 years, and I was having lots of successes, but I was quiet about it because my colleagues, including the physicians and my psychologist buddies, were saying this is not possible. So I was quiet for a long time until I read Dr. John Sarno's book and started to recognize that I was not so far off the beaten path in helping patients. And as I got more experience over the period of 16 years in helping patients become what I call shift into pain recovery, I was quite amazed. And so whether you have headache, backache, neck pain, IBS, complex regional pain syndrome, I could go on all day long. Those fancy medical symptoms really don't mean a whole lot to me, and I know maybe to providers, but it really is coming from one system, the nervous system. And what I want to share with folks is that when we actually learn to shift a nervous system, it actually starts to unfold into that sense of safety. And so what's that mean? As a pain psychologist, I'm very practical. So one of the things I do, and especially on Sunday, I have a list of speakers, world-renowned speakers, and my day on Sunday is about how do we create safety and how do we get safety into our days every single day. So I'm really big on breath work, and I'm very big on mindfulness meditation, both formal and informal. But one of the biggest things that I teach my patients, which they struggle with from time to time, is they go back to the old ways, right? But the new ways, here's what I teach them. I teach them to get to know the nervous system. And this may seem so intellectual, but it's actually not intellectual. So if you know when you're unsympathetic, when you know you're scared or angry or ruminating, it is incumbent upon you to figure out, how do I get into safety? And this is where practical skills come in place. I'll give you an example. If you're starting to notice tension headache, or you're starting to notice symptoms of diarrhea, if you're starting to notice a headache come on, or your back is starting to gnaw even more, at that point, it's a teaching moment for your nervous system. What you do and don't do, that will make a prediction and reinforce the system of danger or threat. And so what I tend to do is I sit with my patients, and I like to do this in groups. I run lots of large groups. And in the groups, I get everyone to be in sync with their breath, to create a sense of safety. And I teach skills, and one of the biggest skills I can teach this group, whether you join us on this coming weekend or not, this next week, is for you to get to know your nervous system. And what I mean by that is know when something difficult is showing up, and know that you have a choice. No matter what anyone has told you, whether you say you cannot, you've tried breathing, you've tried meditation, that might be true, but sometimes you need it to be organized in a way that you have a daily rehabilitation program. And what that basically means is, when you can actually recognize that what is the truth using modern pain science, which we will do on day one of this summit next week, when you understand what the threat is and know the truth. I liken the information that we're going to be sharing this coming week, next weekend, to as if the world is round. A lot of providers and patients alike believe that what is causing chronic pain is structural, nerve, and tissue damage. And I'm here to tell you that's false. It does not mean that that's not true. I'm just saying it doesn't better account for why the pain is still consistent. So coming back to the first education, I often educate, you've got to know your nervous system, know which level you're on, whether you are feeling threat, what is safe, and also know that sometimes the way the nervous system works, it's in service of protection. What does that mean? When you cannot fight or flee from your life problems, if you cannot fight and flee, you don't know how to deal with the uncomfortable sensations in your body. When your nervous system cannot fight or flee, it drops us down into a state of freeze. Now, as I was listening to Stephen Porges and David Hanscom, I saw a couple of messages at the bottom, and I wanted to address it right now. One of the messages I saw is about ACE. And one of the messages I saw was about that, I don't have trauma. And so let me just address this. It's not so much whether you have trauma or not. What I want to show you is your biography becomes your biology. And what does that mean? That basically means is your nervous system is constantly shaped and reshaped by the things we experience. Let's pause there for a second. When you notice something shifting in you, whether it's a mood shift or tension, it is incumbent upon you to use some sort of skills to move into a sense of safety or even connecting with people. Now, I know this may sound silly, but when I'm ruminating, I actually go hug my dog. I have a wonderful chocolate lab, and my dog sighs with me. So what is that doing? I learn real quickly, I shift out of my rumination. So going back to what Stephen Porges was saying is there is science to the things, but we just need to organize it. And the summit for next week, we've organized it for you, from threat to safety. And of course, thanks to these guys, they permitted me to do the safety part. And the safety part is we have different speakers to teach you skills to be able to create a sense of safety when you're with someone, when you're not with someone, whether it's a breathing technique, whether it's expressive writing in a very specific manner. The bottom line is this is your life. And if we wait for people to tell us that the world is round, you will continue to suffer. David and I really started this whole thing, and we're so thankful to Stephen Porges to join us in this journey, because We do not wish for people to suffer unnecessarily. Suffering is part of life, but it is not, you don't need to suffer unnecessarily. And so we want to provide you a set of truths and speakers and experts for next week, and also to show you how to rehabilitate your life and reshape your nervous system.
Well, that is incredibly inspiring. Thank you for that. What I hear you say, Les, is about, so from a personal perspective, all of us starting, there's a lot of clinicians in the room, but we're all people with bodies and nervous systems, and that I hear you talking about empowerment, that this is actually a medical model that really empowers the person to be in control, have more control of their state of health. And then I also hear that it is about discipline. It's about, like you're saying, stopping and doing, right? And I heard you mention expressive writing therapies, breath work,
Mindfulness, forming and
mindfulness.
informing. Yeah.
Okay.
Yeah, absolutely. And I got to tell you, this is the one thing that Steve Porges and David Hanscom knows, is that we need to laugh. And let me just kind of ask if people can put it in the chat box. I'd love to hear how many of you have actually had a good hearty belly ache to the point where your stomach feels like it did Pilates. I mean, let us know in the chat box. I'd love to really take a look at this, because one of the things I love to do, Anna, is on a daily basis, I actually laugh heartily at the silliest things. And if you don't know who to laugh with and what to laugh with, listen to a joke, or go to YouTube and listen to Just for Gags, or watch that. Play is important. And Stephen Porges really talks about this. Play is safety, connecting with people, laughing. That actually helps reduce that intensity of threat and actually puts the nervous system into a sense of comfort and safety. Think about it. When the last time you laughed with a group of people or friends, did not just feel so good. And that helps in pain. We used to think this was just pop psychology, but based on Stephen Porges' work, we know that laughter, play, connection provides a ground for restoration of your nervous system and pain.
That's great. So for the clinicians that this is applicable to, can you just like say, how does this change your one's practice, one's medical practice? It's, I mean, it seems like it would be absurd to tell a doctor to say, hey, have you journaled lately, as a way to your healing, right? Because that's not what we normally hear. So can you share with us, like, what would you say to clinicians about how they should be sharing their helping their clients?
Yeah, Hannah, sorry, my mind wanted me to share this with the whole group. It's not so much to the physicians, have they journaled lately, as the question I would ask physicians, psychologists, physical therapists, occupational therapists, anyone, nurses, any healthcare provider. I wouldn't ask that. I would ask, have you met your nervous system lately? That's the question I would ask. And on a serious note, is one of the things that, please, one of the biggest things I've trained residents and therapists, and have a big group of physicians that I train, and I emphasize this, and this is, again, thanks to the work of Stephen Porges, and this is why I'm so grateful to him, and with David's work too, is this. So Stephen Porges really, he has a one-liner, so I'm going to steal one of his lines. Steve, so I apologize, I'm going to steal one of your lines. And it's a big one I use with my groups that I teach in patients. Your physiological states, I'm going to slow down here and repeat it a couple of times. Your physiological states determines your psychological states. And a lot of therapists and doctors, including psychiatrists and healthcare providers, they believe that the reason you have the pain is because of all the negative thoughts. Well, let's just pause there for a second. When you are laughing, when you are enjoying, when you're connecting, feeling safe, where are the negative thoughts? The point in case here is this, is that when we are feeling defensive, we're in sympathetic drive, fight or flight, when we're feeling scared or angry, what happens is that's what gives birth to those negative inner narratives that are overwhelming and intoxicating. And we have different sciences, the skills that I use, and David also uses this, is to be able to learn to step back, pause from the inner critic. But the inner critic exists because of the nervous system's defensiveness. So When we have negative thoughts, it's not because you're weak, and don't let anyone tell you that. That's my feedback to everyone. Do not let anyone tell you that shame is because, of something that you've done. The reason we feel what we feel is because of the nervous system's hierarchy. So we need to have connection, safety. So if you don't have people to hang out with and you don't have the right people or treatment, this event basically walks you through the new signs and the things that you could do.
I know we've talked about this before, vulnerable communities, vulnerable people who have extremely stressful realities relative to others. What does this mean for people who live high stress lives that they don't really have control over?
Steve, I did a study and even wrote a paper. Could you tell us a little bit about how that impacts the COVID? And he's very bashful.
Well, the part we have to realize is that if we carry with us a trauma history, we're carrying with us a pre-existing condition. If the trauma history has retuned our autonomic nervous system, it's that latter point. And this is the problem when people think that trauma is a spreadsheet. Like ACEs treats trauma history as if it's a spreadsheet. Polyvagal theory says that's useful information, but the real information is the experience. And so I use this terminology of what polyvagal theory gives the individual. It shifts their personal narrative from a spreadsheet of events to a spreadsheet of sequential experiences, bodily feelings. And that's who we are. And also, when David was talking about medicine, we're really the product of 400 years of, let's use the term, Cartesian worldviews. And that had a lot to do with Western, not just philosophical, but Western religious views of separating spirit from body. And in separating that, we gave up feelings. And our body, really, our lives are driven by our feelings. And our feelings actually open up and close portals in our brain. So if we want to be creative and, quote, really intelligent, we better be out of states of threat, which means we should be safe with other people. So back on your issue about COVID in the study, basically we found out that if people had trauma histories and their subjective reports about the autonomic nervous system were describing that their autonomic nervous system was, quote, retuned to be more defensive, then the mental health symptoms associated with the pandemic were exacerbated. We don't have information on whether or not they got the disease, but I would imagine that it shifted their immune function as well and their level of inflammation, because many of them under threat would be already inflamed. And then the virus just puts them over a threshold and their bodies then collapse. So if we were a more informed society and realized that our own personal histories, whether we have internalized threat and stress and retuned our autonomic nervous system and respected that as a pre-existing condition that had a high priority to be rehabilitated, meaning coming back into states of safety, we'd be happier and healthier. We'd be a happier and healthier society. One final statement, and that is, of course, we're all aware of what's going on in the country. And this has really been a ramping up of chronic threat. And the issue is, what does that do to people? What does it do to their decision-making? What does it do to their accessibility and their ability to process rational thoughts and discussions?
That's great. I think that this is we're actually naturally doing this right now. We're posing some questions. I'd love to bring some of the questions into the room that I'm getting from the chat box. And I'll invite either one of our three speakers to drop in and raise your hand and go for it. One of the first questions we got is, what about just age-old wear and tear and its effects on the physical issues? And there are things that happen to us that are not related to stress. How do you bring that type of chronic pain into the conversation? Either
Okay.
David or Steve or Les.
Let me just talk for one moment about the aging phenomenon. Aging is real. Let me share that with you. There are things that do change, including the neuroregulation of your autonomic nervous system. But there are markers that we can be aware of, and there's a degree of, I use the term neural exercise. So when Les was talking about play, I see play as a neural exercise. Movement is a neural exercise, but movement with other people, whether we call it playful dancing or team sports, or even walking while talking or jogging while talking. By bringing the other person into the mobilization mode, we are actually performing a neural exercise of this neuromammalian ventral vagal circuit that is the one that choreographs our autonomic nervous system to keep us in states of safety and gives us the resilience to deal with threat. So keep exercising. But exercise doesn't mean sweating.
Okay. So if I was to kick that back to you, Dr. Porges, that aging is real, but aging can be modulated. Like there's aging that's the biology, but then there's a physiology of aging that can be supported and
I want to emphasize that neural exercise has really been my life focus.
Okay.
And as I've aged, I realized that physical exercise needs to accompany the neural exercise. But the point being, if we are to be healthy, self-regulated or co-regulated individuals, we need a nervous system that works. And we know that that nervous system of connectivity will not work if we're under chronic threat. And so we need to understand what is it that our body wants to move into these states of safety. It wants the ability to connect. Now, when I make that statement, there are a couple features that we all will understand. Features of connection have to do with intonation of voices. Is our voice welcoming? Facial expressivity. Do we have warm looks in our face, or do we have a hostile scowl? Are our gestures open and accessible, or are we defensive? When a person talks to us, do we reflexively turn away, or do we lean forward and engage? All these behavioral reactions trigger physiological responses in the other. And I have a term that I use, I call it biological rudeness, which means I engage you and you walk away. And I used to do this in my workshops to see how people felt. And I even had experiential that I called the reluctant therapist, and where you have a client and a therapist, but every time the client said something to the therapist turned away. And people knew that they would get anxious and upset from that, but they still, because I warned them beforehand, but they still got furious in that experience. I want to reflect back on something that Les said. When he started his whole presentation, he had you take a deep breath, and he had you exhale slowly and to vocalize while exhaling. What he was doing was exercising the vagal regulation of the autonomic nervous system. Because when we exhale slowly, that's when that vagus nerve starts to inhibit our sympathetic activity. And every time you see someone getting anxious, they reverse the way they breathe. They inhale longer than they exhale. So they literally huff and puff, and they get their bodies worked up. So we can see this in ourselves and others, and where we shift our physiology to support a behavior. And then once our physiology shifts, our mental state shifts with it. And then we start creating narratives to justify why we're angry at the person across the table from us.
That's great. I'm going to share another question that's in our chat. And the question is, the general question is, would you consider things like acupuncture and polarity medicine and somatic experiencing enough to resolve chronic pain?
No.
Great.
Okay, so I want to jump so I got muted for a second. I think those Les did that, so I couldn't talk. And I have a problem because surgeons don't smile. That's another problem. So this is a problem, but we'll work on this. Here's the deal. Okay, everybody just take a deep breath, like Les said, and just relax for a second and try to listen to what I'm trying to say. So as I look at the chat board, there's acupuncture, there's massage, there's medications, there's counseling, there's all sorts of stuff. You cannot fix chronic pain. So the three parts to solving chronic pain, by the way, is chronic disease. It's not just chronic pain. So the first step is understanding the problem. So education is really, really critical to understand what's going on. It's a complex problem. You can't understand any problem until you actually understand it. Then there's principles behind the solution. So you become aware of the problem and the principles behind the solution. I did write a book, Back in Control, A Surgeon's Roadmap Out of Chronic Pain, that delineates the evolution of chronic pain. There's a whole sequence that occurs. So you have a complex problem that medicine is throwing random simplistic solutions at. So everything works a little bit in chronic pain, but nothing works in isolation. So everything you mentioned is excellent and good, but it's a combination unique to the person that helps. So the first part is awareness. The second part is understanding it's a multiple faceted problem. You have to treat every aspect of it simultaneously. It's like fighting a forest fire, which in California right now is a bad metaphor, but everything counts. So sleep could be 20%, exercise 10%, acupuncture 20%, anxiety another 10%. So there's different things that work for different people, anti-inflammatory diet, et cetera. All these things contribute, but nothing works by itself. So the second part is treating every aspect simultaneously, but you have a complex problem with an individual. The most critical part of this process is you take 100% control. So if acupuncture works, great. If it doesn't, great. I will say what I've learned from Steve and Les and DR, we're trying to get him on the phone here in a second, is that on a given day, it's a different set of things. Like for instance, the breathing. Let's say you're fired up and you're anxious. Just do some deep breathing, calm down the nervous system. That's not going to solve chronic pain, but it's going to calm down your nervous system for the moment. So this is all a very dynamic day-to-day process. We just released tomorrow, actually, was called the DOC journey, direct your own journey, care journey, so the DOC journey. It's a straight line process from A to Z that takes you through the process that Les and I have been doing for a long time. And Dr. Clawson also uses the same process. Steve right now is sort of our quarterback because he's not in clinical care right now. But it's been so much, I think what Les and I are both seeing consistently is that we do group sessions. Group therapy is powerful. We watch connection happen. That's powerful. And so it's a process that's a day-to-day process, learned skill. As you learn the skills to regulate your body's autonomic nervous system, you're free, you're safe. So safety can occur in many forms. So that's where I'm just trying to address a bunch of questions on the side table. The answer is yes, everything I saw mentioned works. If it works for you and it works in combination of other tools. The other key issue I just want to really emphasize that chronic pain is solvable. This new term called medically unexplained symptoms to me is one of the worst things I've heard in my entire career. Your body's inflamed, your metabolism's up, your nerve conduction actually increases. You shut down the blood supply to your gut. And Steve can talk about this for a second. You've actually thrown off inflammatory markers in the brain. Your brain actually becomes inflamed. So everything's wrong. I mean, your whole body's inflamed, high metabolism, the whole thing, everything's wrong. So of course you have symptoms that are completely medically explained. So to me, sort of the final nail in the coffin for me as far as the medical system is this term medically unexplained symptoms. Maybe 5% of symptoms, this has been documented, are due to a structural problem. 95% depends on your body's chemistry, your blood flow, your blood pressure, your inflammatory process. That's what causes symptoms. So again, it's an interaction between your circumstances and you that create symptoms. We're treating the symptoms out here. And I came up with the term that I will mention today, whether Les thinks I should or not, is that I want to get rid of the word integrated medicine. Now, why would I want to do that? Integrated medicine takes account into the circumstances in the person, and they work on it. People do get better. It is medicine. What we call integrated medicine is medicine. When physicians, and I'm part of this group, talk about the term integrated medicine, there's a little bit of a pejorative term or energy to it. They're wrong. So they have the data. They're actually doing it. So my proposal is that what we call integrated medicine is medicine. And what we're calling medicine right now, I'm calling disintegrated medicine. It's not medicine. We're treating symptoms out here. It can't work. It doesn't work. We have an opioid crisis, alcohol addiction crisis, chronic pain crisis. You can't tell me what we're doing in mainstream medicine works. So honestly, I'm excited. In fact, I just feel like that with our group that we meet every week on and talk and we learn from each other, that there's so much data that's there that we're having a hard time keeping up with it. So we look at this conference as the first of an annual conference that each year will keep moving forward faster and faster. But we're excited about this interaction, and this whole process of chronic pain is so solvable. Even a lot of chronic diseases are solvable. And I hope Dr. Clawson hops on. He's jumping into all sorts of things. This is a very solvable problem.
David, I'm wondering whether I can just mention something and kind of summarize what you just said.
Yeah.
And I was also looking at the chat box to make sure that we're all on the same page. So I think we are very clear in sending the message. It's not that acupuncture doesn't work, or diet changes doesn't work, or doing yoga in cool tights doesn't work. We're not saying that. We're saying everything works in its own realm.
Right.
What I wanted to emphasize, what David is emphasizing, and this is this. When you actually just pause here for a second, when you take care of your life, your lifestyle, and you could have the right diet, you could be meditating, breathing, exercising, but when you do not know how to deal with the symptoms that show up, the sensations that show up in your body, and I do not differentiate between emotions and physical pain, because I believe it comes from the same circuitry. So when you have a difficult thought, difficult emotion, or a physical sensation that shows up, you could have the best lifestyle, the best dietary, you can have minimal trauma, or maybe lots of trauma, lots of wear and tear. Let's just pause there for a second. When you do not know and do not have the skills to sit, to welcome the unwelcomed symptoms, that's when you activate your sympathetic drive and we tend to fight and push. And what I want to send a message to everyone here is this: is take care, have a good life, connect with people. This COVID will be resolving as we move forward with a new government and new things, especially in the United States. However, when you do not have the skills and don't have the understanding of how the nervous system works, and the practical skills of learning to sit with those uncomfortable sensations and the skills that actually calm it down, we are reinforcing a danger signal in the body. So it's really important to understand this. Take care of your lifestyle, but have skills that learns to connect with those emotions and sensations in your body, which eventually will desensitize that strong reactivity.
Right. So I love what you're saying, Les, and you're talking about building resiliency. So the stressors may remain there, but it is less triggering because you have these skills that allow, and like mindfulness is a great example. It creates some distance between your life and the stressors and your sense of safety or sense of self.
I'd like to kind of add to that. There's another thing that reduces the fear or the threat of the symptoms, and that is an understanding of how the nervous system works. And so when we start seeing, like I try to talk about, this evolutionary organization that's part of who we are and how the nervous system works, then we start understanding why our body is going into states of threat and what our body is trying to do for us. And often when the body reacts to stuff, we get angry at our body and we want to numb those feelings, as opposed to honoring it and learning from what our body is trying to say. So the organizing principle of our nervous system, understanding that, is very helpful. And I want to wrap that back to what David was saying in the beginning when he was going on his journey of self-criticism or criticism of the medical profession. And that is, physicians do not learn enough about the nervous system. They learn about end organs. They don't learn about the regulation of those organs. They don't learn that those end organs, like our heart and our gut, are sending information to our brain. It's not part of their curriculum. They haven't learned that. They don't understand how our brain can impact on our gut, yet everyone knows their gut can react to emotional stressors. We live these experiences, but the training that our physicians get, our medical care staff get, do not provide them with the metaphors, not just the knowledge, but even the metaphors to explain daily life.
Excellent. Thank you.
So Anna, Dr. Clawson is on, I think, if he can.
Yeah, I'm here.
Oh, there you are. Okay.
Can you hear me? Want me to jump in?
You're being looked at by 199 people, so
Okay, hi,
be on good behavior.
Hi, Dr. Clawson. Thank you so much for being with us. My name is Anna, and I just had to take a minute to introduce you properly. We really appreciate you coming here, and want to let the folks in the room know that you are a practicing rehabilitation and medical doctor out of Seattle, Washington. And you strongly believe that the body can heal with non-invasive therapies and modalities. And you are currently the medical director of the non-operative spine care center out of Swedish Medical Center in Seattle. So your fellow colleagues here have mentioned you several times in our conversation. So thanks for being with us. And how would you like to jump in? And we're talking about chronic pain.
Sure. Well, just to kind of pigpile on everything else that people are saying, I think it's important to recognize that our emotional centers, where they're housed in our brain, they're housed right there with our connective tissue and our organ centers in the brain. So they coexist together in the brain, pretty much in the exact same locations. So you have to recognize that it's pretty hard to experience physical pain without having some element of emotional pain. And it's pretty hard to experience emotional pain without having some physical sensation that goes with it. And as Les was saying, we kind of want to run from those aversive sensations when we need to kind of dig into them and figure out what their meaning is, particularly their emotional meaning, because
Back on mute. Mute. Ah, mon Dieu, laisse sortir du Zoom. Bon, merde, laisse sortir. Je suis trop vite.
We have, okay, keep going.
Okay, so anyway, so I just want to reinforce that those things just go together. So when we're feeling some bodily sensation, whether it's up in our neck, our shoulders, our low back, our butt, kind of that myofascial pain, or we're feeling something in our gut, or we have a migraine headache, there is, if we haven't suffered a physical trauma, there's a good possibility that there is an emotional thing going on within us that we need to address. And I'm not going to get into that because I am not an expert in that area. But I think the one thing that I sort of bring to the table is a little different view. I tend to view things in terms of threat versus safety, as we all do. But as all my colleagues know, I kind of start from the ground up and look at things from a molecular and a cellular level in terms of these chemicals, these small little protein communicators that float throughout our body that get elevated when we're under threat. And that threat can be a physical threat, a virus, a bacteria, COVID, or a lion, tiger, bear, another person. It can be malnutrition. It can be opioid addiction, those kind of physical threats. But there's also a category of spiritual threats that elevates these threats, chemicals in our body. And those can be emotional traumas, emotional threats, social trauma and injury, such as isolation, disenfranchisement, discrimination, injustice, poverty. Those are all going to elevate the same chemicals in our body, these threat chemicals, and activate the same system. And then we also have something that I refer to as shadow threats, where our predictive codes, our traumatic memories, our thought suppressions, our emotional repressions that we're not always so aware of are continuing to poke that threat button and get these chemicals going. Well, these chemicals increase inflammation, they increase pain or increase nociception through multiple different areas. They intervene with that pain pathway. And the other thing that people forget is that they increase something called catabolism, or our breakdown of tissues in our bodies. So that's why we so frequently see with chronic threat or chronic stress, things like inflammation in arteries with strokes and heart attacks, or inflammation in the gut with ulcers or colitis or irritable bowel, or we end up seeing degenerative disc disease and spine deformity. So that's kind of how I come at this whole thing.
Wow, that's wonderful. As I'm hearing all of this, you describe real life, right? There's just like not every human being in their life path is managing, dealing, facing change and stress and ailments, and so it really, I do recenter back to what Les said, that it's a big portion of it is our coping mechanisms and our ability to build our resilience. There's a question in the room that maybe Dr. Clawson, you could talk about, is they bring in the question of infections, you know, when there are things that come from outside the system in, how does that relate to chronic pain and our coping mechanisms and the physiology behind that?
Yeah, they're very similar actually, in terms of we have kind of a single response to threat. So an infection, in an infection, you may end up seeing things, like fever and malaise and those types of symptoms. But it's this whole system that gets activated that it changes our metabolism, it activates our immune cells to go after the infection. So interestingly, an acute viral infection can do that, but if you're somebody who has suffered from adverse childhood events or just a significant amount of trauma in your life, that hyperactivation of the inflammatory system and the immune system can actually then cause autoimmune diseases like rheumatoid arthritis and lupus and MS and things like that. So, and those are not viral infections, right? The adverse childhood events are these, emotional traumas that haunt us over time and activate essentially the same system. Unfortunately, there's no bug to go attack, and so sometimes it attacks our own body. So, in these same systems, and in terms of Steve's work as well, the autonomic nervous system goes through various changes in response to defending off a virus, COVID, or defending off a physical attacker, or fending off, an emotional attack as well. So we don't have a huge diversity within us to respond differently to each one of those, kind of different assaults. We tend to use the same system over and over again to deal with all those different attacks.
That's great. So it's pretty special to have the three of you with us together in this in one room, so to speak. And I heard David mention before that you're hoping that this summit be one of many that are hosted over the next coming years, because it's such an important conversation. What's your hope for, I don't know, 5 years down the road, 10 years down the road, the state of medicine and the state of common understanding of chronic pain, and what's your hope? Yeah, go for it.
Oh my God. Yeah, there's so much here. There's so much interesting stuff here in terms of this. I would hope this would explode. I'm pessimistic that it will.
Oh, come on.
But the way that we're looking at us as human beings and our connectivity, this is a socio-psychobiological phenomenon. So this threat system, the autonomic nervous system adjustments and the intracellular communication adjustments that occur in the body, they get not only represented in physical illnesses and chronic disease and chronic pain, but this very same soup gets reflected in how our brain works. Okay, so when we're under threat, we have a number of different ways that we actually present in the world in terms of our reactivity or lack of, our tendency towards mobilization or immobilization, our tendency towards anxiety or our tendency towards depression, our tendency towards rioting, so this is all kind of a same soup thing. So it goes literally from trying to get each of us as individuals to feel, well and healthy, to all the way up to, sort of global political socio kind of policy that is going to improve health and wellness for everybody. So so Dr. Porges has repeated to me over and over again, it's a single system, it's bidirectional, which are very important, and that it also goes beyond our own soma. It goes beyond the boundaries of our body. It is part of a single social system as well. We are all one big system. So, and then I always like to say it may even go beyond that. I got mitochondria, and my cousin the tree got chloroplast. So we're all kind of connected somehow.
Right on. David or Stephen or Les, how would you answer the question? What's your hope? What's your hope about this conversation if you could fast forward 5 years from now?
Well, I'd like to hear Steve and Les first. I have my ideas. So Les is teaching me to listen. So Steve.
Good job, Les.
So Les, what do you think? What are your thoughts?
I honestly believe that this is the mission of the summit. Is the hope is, and it will. Dr. Clawson, hang tight. The reality is we know the reality. There will always be this push and pull, and I don't do power struggles. I basically keep putting forward what needs to get done, and there'll be a flock and a group of people who will hear what we have to do. So my hope, desire, wish, and I claim it, is that we will see change. We are in a state of change, and this flux, whether in the United States or around the world, is individuals with chronic pain are sick and tired of being told nothing can be done. So we're starting with this pain summit, and the more to come. What my hope is for next year when we do this pain summit is to have workshops just focused on specifically a 3-day rehabilitation program. And maybe 2 days of psychoeducation. I'm breaking that up. So I think we will see that. But my hope is for anyone here is to take this back to those who touch you, treat you, who know about you, and to share the messages. There's a new paradigm coming, and it's going to happen.
That's great.
So my comments are really simple or similar. I think I'm optimistic, but I'm also pragmatic. So we're going to put this intersect there. And I like to use the analogy of birthing rooms in hospitals, because birthing rooms only evolved in hospitals because there was pressure by prospective parents. They wanted that. So it was a financial drive on the hospital system to enable families to be together during the birthing process. I think this is happening already in medicine because there's so much of utilization, or let me say this term, so many people are spending money on treatment models that are outside the general realm of medical practice. And so it means that medical practice is not serving the needs of the constituency. So on that level, there's a pragmatism, but on an emotional level, an ethical level, I think we know, I will basically give you a quote of what I told the director of the National Institutes of Health about 15 years ago when I was interviewing there for an administrative position. I said, we know too much about medicine to allow it to be practiced the way it is. That was the last time I saw him. So I did not get the job.
I was going to say, did you get the job? Great. And David, it sounds like you wanted to answer as well.
Yeah, I mean, we meet every Wednesday, this group here, plus about another 100 people, and we talk about these concepts and move it forward. And a bunch of things have come out. One of them is that the group setting is probably the home run for treating chronic disease, not just chronic pain. Second of all, the autonomic nervous system explains a lot. We would like to get that into medical schools. So we're actually thinking about, we actually are starting to outline a medical school textbook to start put this together. We have if Susie, I think you had the plan A by chance. Our group, Dr. Porges, myself, Les, and a couple other people, Dr. Clawson, put together this thing called Plan A, which represents 12 categories of things you can do to lower your inflammatory markers. So it's practical. And to me, it's a call for action for the United States to come to a wellness model instead of an illness model. Every person that's dying of COVID has a pre-existing condition. Every one of those conditions is associated with elevated inflammation. That's the only difference that we can see. So what's happened inadvertently as a result of this group, we have this plan A to deal with COVID. And then we've also developed a document called A Structured Approach to COVID-19, because we think this pandemic is solvable tomorrow. We have existing resources that are effective, that are not being utilized in an organized manner. So that's also part of this wellness model of care. But the final thing I'd like to say is that we now have data. Again, it's not new data. We're just mining old data that shows that creating safety, in other words, talking to the patient, understanding the person and their coping skills in his or her circumstances, heals. That's hard data, what Dr. Porges has allowed us to do. And now Dr. Clawson, through his sort of insane knowledge about chemistry and cytokines and all this stuff we had forgotten about in medical school, we have data that says, look, if you don't talk to your patients, you're physically harming the patient. You could solve a big part of the healthcare crisis by doubling, tripling, or quadrupling the reimbursement for time spent with the patient. That's the problem. None of this is going to happen unless we can talk to our patients. So that is my dream. If I had one dream to leave behind, somehow flip the paradigm where that is number one. And the final part of that, again, I quit spine surgery, is quit paying for procedures that have been documented to be ineffective. For instance, in spine surgery, it's now $20 billion a year. The success rate for a spine fusion for back pain is 20%. That's it. And we're still paying for it. So there's things that could be done really concretely, I think, with this group's data and white papers and energy. So I've learned the keyword is called persistence. Just keep, like Les said, one step at a time. You just keep plowing ahead. But we do think there's some real concrete things that can actually happen. But my final plea to this group and to your friends is please demand the change. We're here. We're happy to help move it forward, but the change is going to have to come from the patients.
That's wonderful. Thank you. Well, I think that we're hitting the closing of our time. Any last words of love and wisdom from our presenters before I bring us into this forthcoming weekend?
I'd like to make one comment, and that is to stop thinking about treatments and start talking more in terms of interactions. So even in the discussion of physicians talking to their patients, it's really physicians having a discussion and being accessible to their patients. Because if they start thinking that it's a prescription and they have to talk for 5 minutes, they'll talk for 5 minutes, bill it off, but it will actually be threatening to their clients. So the issue is to understand what the process is that they're trying to accomplish. And David's using the word talk to, and we intuitively understand what he means by that. It's create that connection, the connection of trust and relationship that is our biological imperative, that enables our autonomic nervous system to shift from a state of threat. And remember, when everyone goes to see a physician, they're going there for evaluation usually. And evaluation is a trigger to our nervous system to be in a state of threat. And now the most important thing is to downregulate that threat response, because even if there's something you want to tell the patient, if they're in a state of threat, they will not even understand what you're saying. They'll be in an inappropriate state to process that information.
That's great. One question talking about the summit is, I understand it's organized very thoughtfully. The summit begins Friday, runs Friday, Saturday, Sunday, and that there is a progression that is planned. Could you give us a little information about that?
Les, you want to grab that one?
Sure. We start with day one on the facts with some world-renowned speakers from neuroscientists, and Stephen Porges will be also discussing the polyvagal theory. Day one talks to you about the truth and the threat and what keeps this chronic pain. And to some degree, it begs the answering the question is, why do you still hurt? When no one else can provide you that answer. And as we shift into day two, we talk about being aware of what is it that needs to start becoming reshaped in your daily life, specific things to do. And in that process, we really awaken things that need to be addressed, whether it's unforgiveness or whether it's certain things that you can do to create a sense of connection, which then shifts us into day three, which is about safety, which is my day. It's all about what do I need to do to communicate, to send cues to my nervous system, my brain and body, a sense of I can heal, meaning that specifically, what can we do? And a great speaker who I wish had joined us here, Deb Dana, and who takes Dr. Porges's work and transforms it. And she's a licensed therapist. And in my day, she also walks us through what we can do. And she talks about befriending the nervous system. And that's going to be great. And the part that I'll be talking about on Sunday is basically why group really works, and emphasizing the ventral vagal system and the things I actually do in group that actually can stimulate that health growth and restoration of the nervous system. So ultimately, each day as we go through it, it's going to be live. It's unlike any other summit. Most summits are recorded, but this summit, David and I are really big, and just to bug David and tease David a little bit, we want the presenters to present in 20 minutes their information and have 10 minutes of live question and answering with the expert. And at the end of each day, we're going to present to you stories of hope. So not just about back pain, neck pain, but a variety of patients that David and I have had and how they got better based on each day's theme for that matter.
So I just saw an oxytocin comment pop up in the chat. So I'd like to ask DR to comment on Sue Carter, who happens to be married to Steve Porges. So we're all Sue Carter fans. DR, you want to encapsulate Sue for a second as far as oxytocin and groups? You're muted. Tim, he's muted.
I look at Sue as kind of being the mother of everything oxytocin. So oxytocin's been known as the love hormone or the bonding hormone, and it's a little bit more, has a little bit more diverse function to it than just that. But I think the combination of Sue's work and Steve's work around the need for social engagement and how important that is, and oxytocin being one of the chemical mediators of sort of the social engagement system and the sexual reproduction system as well. How they kind of work hand in hand, and how they not only facilitate us getting along with each other, but they also re-regulate our nervous system. They drop inflammation in the body. They promote, instead of catabolic hormones like cortisol, which I see is flashing up on the chat a little bit, anabolic hormones, the testosterones, estrogens, progesterones, things like that. It's all promoted by that. So we actually heal. We become anabolic. We build tissue. Our mood goes up. We're prone to wanting to be open and connected with other people, versus what life is like when you're running from the tiger. When you're running from the tiger, it's really not a time to, be empathetic and bond. You'll get destroyed that way. And so we shift our physiology in a different direction, and oxytocin goes down, and a lot of other things change in our bodies as well. So you can pull on all of these threads, and they all start to line up, together and kind of pull in the same direction. That when we're under threat, we're one type of person, and when we're under chronic threat, we're falling apart at the seams as well. When we're in safety, we're another type of person, and we're highly social. We feel well. We connect. We reproduce. We love, that type of thing. So Sue will talk more about that on I think it's on Friday.
That's great. So to the wonderful people, there's almost 200 people who spent this last hour and a half with us, and we really thank you so much for being with us. All of the more details than you can imagine sit on the opencenter.org. opencenter.org. It's the New York Open Center's website. This summit will be live, like Les said, but it will be recorded. So if you can't attend all 3 days, you will be given the audio video recording, and you'll have 30 days to drop into it and go more deeply. There are CEs that are being given, so continuing education credits given to a whole host of different practitioners who are participating in the summit. And this is the time to register. We thank you so much for being with us. Spread the word. As you can tell, this conversation is very pioneering, but it's also super, super accessible. It's super applicable. And you four gentlemen have been so warm and easy to connect with. And I think that's also just your embodiment of the work. And I just want to thank you so much in advance for leading the charge and being so wonderful, and for being with us next weekend. So thank you so much. And Susie, you are a producer of this event. Is there anything that we've missed that we should mention, or have we said it all?
I think you guys have said it all. It's
right.
going to be an amazing event. It's going to be amazing.
Fantastic.
Thank you, Anna. Great job. Thank you.
Thank you. I know David has a very lovely website that's easy to drop into, and it just provides a world of more information. I know Les does as well. Stephen, you have hundreds of articles that can be searched online, if not more. So just an
We also have a webpage, stephenporges.com, and now it's polyvagalinstitute.org. So there's 2 web pages.
Fantastic. So with that said, thank you so much, everybody. Happy Sunday, and we will see you next weekend. Thank you so much.
Thank you.
Thank you.
Thank you.